Thank you, everyone. And thank you, Laura, Leah, and Maria, for the invitation as well and giving us the opportunity to share the work that we've been doing. So, as Laura mentioned, my name is Sarindi. I am a PhD student within the Patient Experience Research Center. And I'll hand it over to Carole first, introduce herself, and Susan next, and then we will kick off with our presentation.
Hello, I'm Carole, and I have joined the group as a lived experience person. So basically, the experience that the people on our research have gone through, I have gone through myself.
Hi everyone, I'm Susan. I'm also a lived experience partner, and exactly like Carole, been through similar experiences to people taking part in the study, and I'm a mum of five as well.
Thank you. So we're here today, the three of us, to share how we are addressing health inequalities through community partnerships and research. And our project is called Break the Barriers, where we want looking to improve maternity care specifically for Black, African, Caribbean, and mixed Black families living in Northwest London. Carole will share a little bit more later on in terms of why this is really important, especially in Northwest London, and why this is something that we need to focus on. But before we start into the project itself, what I wanted to share is from a researcher's perspective, it's really important to think about the different ways that communities can be part of research. So you'll see here in different colors the different levels of how that can look like. So at kind of the basic level, we've got in pink, which is participation. And what that means is where community members share their experiences or provide data as subjects of a study, but they don't necessarily shape the research. So this could be, completing a survey, they're being interviewed by a researcher. So they're just sharing their experiences, and the researchers then take that away, analyze it without that individual's input. The second way that communities can be part of research is through engagement, where researchers might share, towards the end of a project, the kind of the key findings, and they may listen to feedback from the community around their work, but ultimately the decisions around the research stay with the research team. The second type of different way that communities can be part of research is involvement. And, as community partners within the BRC, you'll be very familiar with this when you're supporting the different themes. And this is where community members help plan or guide research. They may be helping the researchers shape the questions or reviewing study materials, but they don't necessarily run the study themselves. So it's, at the end of the day, the researchers still conduct the data. And then the lastly is co-production. So this is where researchers and community members work in partnership as equal partners to design, carry out, and share the research. And the decisions around the research are made together, and everyone benefits from working together. But what's really important, what we want to show you today, is that in one project, you can have lots of different ways that communities can be involved, and it really depends on the research purpose and the question that you're trying to answer. Now, what we thought would be helpful is, thinking about when you're trying to do a project as a researcher around health inequalities, what do you need to think about and as a researcher before you have community members and lived experience come in. So one thing to really acknowledge is with health inequalities, there are, this is speaking to, global majority communities that are being affected by the issue. And we have to recognize that within medicine, within healthcare, there have been past harms that have been done to global majority communities. And as well, we have to acknowledge the role of racism. And that's really important that we name that because that then affects the types of policies that are put in place, how funding gets put towards research, who gets that funding, and what kinds of research questions then get answered. And because of all of these things, because there's sometimes not enough, clarity or transparency, this can then lead to research and health service mistrust around that. So this is where we then see global majority communities may not be part of research. They might not be engaged. They might feel distrustful around research. So keeping that in mind, myself as a researcher, I had to think about before, working with Susan and Carole, and we've got three other lived experience partners who are part of this work. For me, why am I here? Why am I interested and wanting to do research around health inequalities? And what are the things that I believe and value? And also, really importantly, what do I gain from this process? The second is thinking about who I'm doing this work with. And it was really important to me that I didn't just go to the usual suspects, so just only speak to the people who are already very engaged in research, but actually reaching out to other people who have experiences and have something very valid to share, but don't necessarily, one, feel like the research process will make them feel heard, or two, they don't know how to get involved in those opportunities, even though they want to. The second is thinking about funding. And so it's really important that if I am bringing in people with lived experience and community members, that I'm supporting them and being able to reimburse them for their time. But also, if I'm holding events in person, being able to, hire spaces that are within the community that people feel comfortable with, as opposed to just asking people to come into the university or to the hospital to participate where that isn't comfortable. But also importantly, being really clear about what the project can and can't do. And as a researcher, especially as a student, you want to try and solve the world and fix all the problems. And Carole is laughing now because we've had these conversations. But, we can't do everything. We can't fix everything. And part of the project is thinking about really specifically what is it that we can look at, but also acknowledging what we can't do and being okay with that, but highlighting those gaps so that others can build on our work. And the last bit was really identifying the research question. So as a researcher, as a student, I could have said, this is the thing that I really want to look at. But actually, what was really important is actually taking that step back and understanding what matters to communities and making sure the research actually centers the voices of those that are most affected. And being clear about who is around the table, but also who isn't around the table, and being mindful of that and actually reaching out to those. So what I'm going to do now is hand it over to Carole to talk a little bit more about why we're focusing on Black maternal health. Oh, Carole, you're on mute.
From the start, I was really interested in this topic because I was also a maternity champion. And at a group that I was involved with, I met a lady who introduced me to Sarindi. And Sarindi's project was to improve the experience of maternity care for the minoritised ethnic group in North West London. At first, it didn't sort of register with me. So we had a chat. We had a one-to-one, and I could ask questions and I got more information. But what I want you to remember is these statistics that you've got in front of you now, as horrific as they are, with regards to the fact that we've still got 3 times maternal mortality amongst Black women. And also we've got, with regards to the 5 times more report, 54% of respondents face challenges with health professionals. 28% of respondents reported they faced discrimination. 25% of these said that it was due to their race. And then we've also got another area here, which is about the maternity journey. The amount of people that came to talk to us and they didn't know what their actual little book meant, what was recorded in their books with regards to what their pregnancy was like, what was happening with them, what was what were the blood result, none of this was explained. Nobody sat down with them. And then they didn't know whether or not they would have a midwife or just a doctor. There was just so much around that. And so it was important to address these areas, but also the ones that we found out from the people that we ran workshops with. What I want you to remember is that behind every statistic is an individual, a family, friends, and a community. And this was a quote from the 5 Times More report in 2022. It was this sentiment and Sarindi's passion and commitment for this project, the lived experience of my mum, my children, and myself, that made me decide to get more involved in the project. And that is trying to make improvements in Black maternity care. It's as simple as that, just to make improvements. There comes a time when enough really is enough, and you need to become involved to get your voice heard and become the challenge to the status quo. Having an opportunity to become part of something and be able to influence research from the outset is a good place to start. For many of my years, there has been a disparity between the outcomes of Black families and our white counterparts. You will all have the opportunity to read the Embrace Project report and the 5 Times More, because as far as I'm aware, Sarindi is going to be sending those out to those people who attend. Some of, as you can see, as I mentioned earlier, is on this slide. What you will also discover in the information is that it's worse for people living in areas of deprivation. So not only do you have these figures, it can be worse for others. Why is it that organisations are still reporting inequalities in mortality, inequalities that women with purported mental health, Black women with purported mental health issues undergo, and those who go undiagnosed during pregnancy? Why is it that women are still reporting issues around the administration of pain management, the receipt of antenatal care, navigating the maternity journey and services, lack of informed consent, not being listened to? I, for one, do not want this to be the same story for my children, my grandchildren, and my great-grandchild. And I don't want it to be the same lived experience for yours. Your lived experience counts, so use it.
Thank you, Carole.
At the beginning, to kind of start this research project, co-production was used throughout most of it, but especially at the beginning. And in the top right-hand corner of the slide, and you'll see it on some other slides, you'll see that the same dial that you were shown at the beginning of this presentation will just indicate where it is on the level of engagement. So formulating the research question was via co-production, and that was done in a really integrated way, and a way that really involved and brought together the community. And so you can see that there were 5 sessions that were held in the communities, and it was for Black, African, Caribbean, and mixed Black families in West London. So there were 2 community sessions, and we invited the community members, anyone with lived experience. And we also had other sessions which involved local authorities, professionals within maternity care, doctors, midwives, GPs, really a broad spectrum of professionals that could also give their input as to what is needed? What do people actually want? What does the community actually want in terms of improving Black maternal health? And so from those 5 sessions, 89 ideas were generated, and then there was one big final workshop. And with that one, that involved stakeholders, community interest companies, and people from the voluntary sector, and lived experience people as well. So it was another good mix of input. And from there, 5 ideas were pulled out to the most prevalent ideas were put forward to see. So if we go to the next slide, please. So when we held the sessions, before holding the sessions, we actually we received training. So for myself, I became involved at this beginning point, and I was supporting the sessions, the community members. So as a mother myself, and also as an antenatal educator, I was quite embedded in the community. I was attending play groups in the community centres and things like that. And so supporting the women at these sessions who were coming to share their experiences, they could also be quite vulnerable. It was an honour and a privilege to take part. So we did receive training prior to facilitating the workshops, and with this training, it was very appropriate. It was trauma informed, and what we mean by that is we considered the fact that people could be coming with very traumatic stories, and things like giving them enough space, enough time, making sure the environment felt safe for them to share their stories, and basically knowing what to do if somebody, perhaps didn't feel like they could continue. This was not something that, they should feel pressured or should feel, they can stop at any time, and that they are well supported by us, the facilitators. So the training was very helpful to help us feel confident to facilitate and to facilitate well. So we also thought about that we wanted people to think about the solutions to the problems as opposed to staying focused on the problems. So prior to holding the sessions, we thought about that as a group, how we would make sure that we can support the conversation, staying useful, staying on track, but also not, making people feel rushed or uncomfortable. So all those things were considered in advance.
Oh, Carole, you're on mute.
I always do that. I'm sorry to the audience. Our facilitator training enabled us to obtain the information required on maternal health outcomes and care experiences to benefit future families by reducing health inequalities in the maternity space. My lived experience enabled me to identify with those around the table at the workshops, which allowed me to build trust with my group and ensured that they willingly accepted I got where they came from. Being a doula enabled me to hold the space so that all stories could be shared, if that's what was needed. I provided birth debriefs with others who wanted to speak with me personally. However, as Peter Drucker said, the most important thing in communication is to hear what isn't being said, which means True communication goes beyond words. Not everyone will speak out in a group situation, so there must be flexible opportunities for that. Observing body language is also key. I needed to check in with one of my group afterwards, whose body I noticed tensed up after hearing something that was said. She also teared up slightly. I motioned to one of the leads and she was taken out to share her feelings and the overwhelm she was experiencing. A person's tone, discovering meaning behind the message, facial expressions, slight movements, which can reveal underlying emotions and thoughts, are all important. It was paramount that those who attended felt heard and that the information they provided mattered, and it would go on to help others. They felt part of something, and for some, it was the first time that they told their story. Next slide, please. As Susan mentioned earlier, we had 5 key areas that everything was drawn down to. And as with any productive and effective event, which the workshops were, we were left with quite a few flip charts with a myriad of ideas and solutions. It was left to Sarindi et al. To reduce these to the top 5 themes from the workshops. 1, staff cultural competency and communication skills, which on this slide is headed up improving staff knowledge and training. 2, community advocates, which on this slide is headed up community-led advocacy mechanisms. 3, tailored health education, which on this slide is headed up tailored information and education. 4, tailored mental health support, which on this slide is culturally appropriate mental health support. And 5, effective signposting to non-health support, which is on this slide as coordinated and integration of care. The top 5 were voted on at the workshop with health professionals and community members, at which the intervention of community advocates received the most votes. This result meant many other things that were identified as being most impactful could also be incorporated, because the work of a community advocate could cut across most of the other themes.
Thank you, Carole and Susan. So what I'm now going to talk about is the next step as part of the research. So what Susan and Carole described was setting the study that we did to set the research question. So as a researcher, for me, I wouldn't, if I had just listened to the doctors, the midwives who I started having the conversation, the research would have gone down a completely different path. I would never have done anything around community advocacy. And the fact that we went through this process where we had health professionals, but also the community members, and this was led by, Susan, Carole, and others, we were able to identify something that health professionals, but also community members felt like they had ownership of, and they felt like they contributed. So the next thing that we needed to do was, if we were going to develop community advocates within maternity within Northwest London, we needed to understand what good looks like and lessons learned from people that have done this before. And the way we did that was working together on a literature review. So as Susan mentioned, on some of the slides, we've got a little dial, and now you'll see that the dial has shifted to involvement. And this is to show that there are different ways that people can get involved in the research. And in some places where you're running workshops, that might be a little bit easier. And with a literature review, that it might be more leaning towards involvement. So essentially, literature review summarizes and analyzes existing evidence on a topic to show what is already known, but also where the gaps are so that future research can then address that gap. And there's different steps to this. So the first is you have to define what the question is through your research question. Then you have to set some rules in terms of what types of evidence that you will include and not include. Then you have to do some search, you have to search for that data. Then you have to decide which studies to include based on those rules that you set out earlier. Then you have to collect that information, read all the studies, take out the relevant bits of information that you need. Yeah, then you have to analyze that. And then finally, you write that up and you publish. So I've highlighted the first two steps and the last two steps in green. And this is where I worked with Carole, Susan, and the others. And then the bits in blue are the bits that I did as a researcher. So just to share a little bit more information on that. So to define the research question and setting the rules. So the research question came out from the workshops that Carole and Susan just described. And as a group, we met monthly, and we meet every month. And during one of those meetings, we discussed what kinds of rules, what kind of evidence that we would include. And one of the things that was really important to us was advocacy has been happening within community for decades. And we needed to respect that. And to do that, we couldn't just look at academic papers that were published because we knew the information, the knowledge from community wouldn't be sitting in academic journals. And we needed to respect that. So one of our rules was that we would include academic, but also community reports. I then led the study, searches in different databases. So all papers that are published, research studies, you will find them cataloged in these online databases. It's a bit of a chore to go through them. I went through all the relevant databases, brought out all the papers. So we had about 1,000 papers that came out. Look through them one by one to see what would fit the rules that we had decided, and then extract some of the data. I'm just going to share it now, hand it back to Susan, who's going to share a little bit about the analysis and kind of how we brought it all together.
Thanks, Sarindi. Yeah, so as Sarindi said, this was more of an sorry, I can't see it very well. But you could see it very well. See if I can. Yeah, that's it. So on the dial, this was more at the involvement level as opposed to co-production. And again, you can see because for actually looking at the research, Sarindi was doing that independently, but we still held monthly meetings to kind of review. Sarindi would send us after we had, said what type of studies should be included. We were given time to look at the literature review, give our feedback, and we still felt involved. We still felt very included, and you can see, just by giving any feedback or that it went through stages. So it wasn't all done and then we were just looking at a finished product. We looked at it at different points. So again, we could feel like we were actually involved and we were kind of coming along the way, even though it was Sarindi doing this part. Yeah, that's.
Susan, I think that's you again. Yeah.
Yeah. So another great thing that happened with this project is that Sarindi was quite passionate, and we all agreed that the way information is used, the way data is used, and the way PhD studies are done. Obviously, it can take a long time. However, there's some amazing information and amazing amazing work that can happen, but it can be paused until the end of the project. And what we actually did was decide that, okay, we've got these 5 outcomes that people have said, the community have said, even health professionals have said, this is what Black women want. This is what Black, brown, mixed families want. We have those 5 outcomes, and we decided not to wait. We decided that we don't need to wait until the study is done to take action or to offer services. And so the first one to take place were antenatal classes for Black and brown women specifically. And Hammersmith and Fulham Council took this up, and it was actually started by an antenatal, so it was a mum who was very passionate about it, and an antenatal teacher. They partnered together to produce these amazing sessions, and they're still running. It's been about a year, I think, now, and they're still running and very well funded. And they have a really good take up as well, which again, we're often told, Black and brown women are hard to reach or anything like that. But in this, you can see that the impact, and people are actually liking the offering. So this was the first service that was offered on the back of the evidence. And something to say is that because we have done the work of the research, the council had no issues with saying, yeah, okay, they like the evidence, having evidence to say that this thing is not only wanted, but works. It was a no-brainer. They could easily fund it, and that makes it a lot easier. I hand over to you, Carole.
I remembered this time. Thanks a lot, Susan. I'm going to be talking about the Task and Finish group that was created. We received support from the NHS to develop a pilot project in West London for the community advocate. And on the 19th, of September, we had our Task and Finish group launch. People with lived experience, clinicians, doulas, community leaders, local authority, public health teams, National Health Service maternity providers, the North West London Integrated Care Board staff, and academic representatives all attended. Feedback for moving forward with the role has been vigorously supported by those in attendance. Coming together from the community for the community is all well and good. However, what I loved about this Task and Finish group co-production workshop is that everyone remembered who they were there for. Those mothers who shared their stories and experience from the outset. Everyone was keen and supportive in helping us to realise a first-class community advocacy service for Black families during their maternity care.
Thank you. I'm just going to briefly stop sharing my screen. We wanted to just, Susan and Carole, if you could share maybe 1 minute, because we started late, just in terms of your overall reflections being involved in this project, and then we'll end with some top tips from the team. Is that all right?
Yeah, no problem. Yeah, I'll go first. For me, this project, being involved in this project, I thought I knew co-production. I thought I knew how things needed to be done, but this project has really shown me what it's like to be in a very co-productive project, and I've loved it. I've loved it. I've almost been amazed as well, because thinking, oh wow, it has a different feeling, but that's my major takeaway, is that co-production is very possible, and it's made even easier and even better when a researcher agrees with it, shall we say. understands what co-production truly is. So yeah, that's my takeaway from this.
Thank you. Carole, one takeaway, if that's all right.
Do you know why she said that, people? Because I can talk for England. So that's why she's told me only to do one. But what I want to say is before I get involved in anything, and I think this is a sort of like my words to you, is that before I get involved is I think to myself, do I have the time or can I make the time to get involved in this? And what value can I actually add? And the other thing I ask is, does it sing to my soul? Now, if I was to pull one thing out of everything, it will be about, can I choose two? And they're be very quick. Literature review. Now that I've done the co-production bit, I really and you know, we've done the sort of end part of the actual review itself. I never knew anything about reviews, and I want to now get involved in what Sarindi does. You know, like doing the research. You know, the things that she does on her own. The two green bits now I know. I want to get involved in doing that a little bit now. But I also wanted to say how I have been really lucky with this group. Okay. I have gone through a really hard time this year with a loss, and I was allowed to dip out and come away, and come back in. And that's what I think you need to know, that your group is flexible and that they're there for you. We meet on a monthly basis, and all of the members create an environment where we can speak openly, be transparent and truthful. And without this safe space, no one, including those we aim to serve, will benefit.
Thank you, Carole. I'm just going to share the slide quickly, and Susan is going to just summarize some of the key tips from us as a group.
So this, yeah, these list of tips are what we agreed that we think make it so much easier and better, and for if you're involved in research, community research partnerships especially. Sharing your perspective with support, your experiences help uncover health inequalities, but behind every story is a person that should have support if they need it. Inviting others, making sure that the group is diverse, it really does help the research have more depth. Speaking up about barriers, real barriers, real life circumstances. So even as we've just said, if your time is limited, if you need transport costs covered, these are real things, and the researchers should know. Ask questions, and make sure that the research respects your community. Especially if you're the organizer, it's kind of like a responsibility as well. Push for inclusion. Look around the room. I think this one's really important. Ask who's missing and why, and how participation can be fairer. Think about what could be blocking people from attending. Give feedback. Help make participation easier and more inclusive. And partnership on your terms. You can choose your level of involvement and share only what you're comfortable with.
And that's it. Thank you. Thank you so much.
Thank you, everybody.
Oh, I forgot the most important thing. Oh, I'm terrible. Let me just share my screen again. But one of the things, and Leah's put that in the chat as well, is we wanted to share what we're doing along with community members along the way. And so what we've done is we started an Instagram account, so you can scan the QR code in pink, and that will bring you to that account. But we've also started a blog as well, just to share what we're doing along the way. So please do follow us, subscribe, so that you can get some updates directly in your inbox. And Leah's popped them in the chat too. Yeah. Thank you.